Welcome to the Six Hats podcast, where I, Dr. Shami, a lifestyle and nutritional medicine family doctor, will talk about how women strive to find balance each day by juggling their six roles, being a woman, mother, daughter, partner, business owner, and professional. Hello, everyone. Welcome back to the Six Hats podcast. And today I have Dr. Natasha Andreadis join us. And so she is a qualified and experienced gynaecologist and fertility specialist in New South Wales, Australia, with over 20 years experience in medicine and over 10 years as a fertility specialist. Now, she's also a certified reproductive endocrinologist and infertility subspecialist, making her uniquely qualified to manage infertility and hormonal issues. But what I love about her, she also has an integrative approach, which means she investigates the impact of nutrition, lifestyle, and environment on reproductive health. Now, she has an informative women's health and fertility podcast channel called The Fanny Mechanic and runs a monthly Dr. Tash book club. Also, her current research interests are in music therapy, where she is looking at how music can help reduce anxiety related to gynecological and fertility procedures. Welcome, Natasha.
Hi, Shami. Thanks for having me on.
Amazing. So I know Natasha is so passionate about menopause, and that's what we're going to talk about. And I loved how we were scheduling this podcast, but Natasha was like, no, it has to be after the Menopause Conference. I want to enlighten everyone on what you've learned. And so you went to the International Menopause Society Conference in Melbourne in 2024. Share with us, please. What did you gain from it?
Yeah, look, there were some great talks. I've taken lots of notes, so I'll share them with you as I go. You may have heard of Sarah Davies. You know Sarah Davies. She's an endocrinologist in Melbourne.
Oh, no, I don't actually.
She's huge in Melbourne. She's from Melbourne. She's an endocrinologist, and she has a lot to do with menopause. And I obviously, in going to a conference, you can't attend every single lecture. So you had to be picky with each lecture you went to. So when I went to her lecture, I picked up a few things about testosterone. Yeah, so testosterone is now being used in Australia more for women with going through the menopause, as it's now there is a product called Androfem that women can use. It's a cream and it's administered through the skin, and it can help with low libido, or what we call kind of women who are experiencing less sexual desire. So there's obviously more research coming in through this. With Sarah Davis's talk, she talked about the testosterone and it's how does it affect cognition and the brain. She said that data was inconclusive. She talked about muscle function, that there's less decline in grip strength at 4 years for testosterone compared to people who are not taking testosterone. You can't really say it protects against osteopenia. Obviously, there are other studies that say differently, but overall, from what I gather, is that testosterone is not a harmful drug in women, and you can take it and see how it works for you. And I'll give you another little kind of spiel on another lecture I went to, which really points to probably the benefits of testosterone use in women. So what are the side effects? Obviously, some acne, some hair growth. There's no data on voice changes and perhaps some weight gain, and that could actually be because women actually gain muscle mass rather than fat mass. And there's not thought to be any difference in cardiovascular disease or depression. But overall, you would read the information on testosterone and it would tell you that women's mood improves because they tend to have more energy. So fatigue, as we know, when men go through the andropause, they often experience things like fatigue, low mood, loss of muscle mass. And women often forget that we make testosterone in our reproductive years. So women are quite surprised that it is actually a form of hormone replacement therapy that should be considered really if you are going through the menopause or the perimenopause, because I call it the holy trinity. It's estrogen, progesterone, and testosterone. There was talk about osteoporosis, which I thought was interesting. And one thing that kind of people tend to forget is that if you're on bisphosphonates for osteoporosis and you're going to your dentist, you should probably tell your dentist that you're on bisphosphonates, because that can cause what we call osteonecrosis of the jaw, which is a very rare but very quite potentially serious side effect, and that some people should have what we call bisphosphonate holidays. But really, estradiol for bone health trumps. It's very good for bones. That's one of the major benefits of being on hormone therapy if you're menopausal. There was a talk about endometriosis, and that 1% of endometriomas become cancerous. And if this is to happen, it's most likely in the 45 to 49 year age group. And that if you are menopausal and you have endometriosis, a history of endo diagnosed on laparoscopy, for example, that you should probably go on progesterone and estrogen, not just estrogen, and possibly being on a tibolone or continuous combined HRT is a potential benefit.
Natasha, can I pause there? I'd love to ask more questions about testosterone, but because I get asked a lot. You're absolutely right, because when we think about HRT, as a doctor, we're thinking estrogen, we're thinking progesterone. And that you made a really good comment there, because I've heard so many patients come in saying, well, I was just started on estradiol because I don't have a uterus. So I would love for you to share why it's so important. We need progesterone as well, despite having
I mean, progesterone can be good for lowering anxiety. It can help people with sleep.
Yes, that's right.
And it works on the GABA receptors in the brain. And so and it could also be kind of breast protective as well. So there are benefits in taking progesterone, potentially, not just estradiol when you don't have a uterus. So again, that's a very individualized, thing when it comes to each woman. We'll talk about the progesterones in a minute, because as you know, there's progestins, which is very synthetic, and then progesterone, micronized progesterone, which is a different type of progestin. So the main thing is about progesterone is it can really help with sleep and lower anxiety, and also perhaps reduce palpitations. A lot of women, as they're going through the menopause, experience lots of palpitations, and giving progesterone may help reduce the palpitations they experience. Yeah. Any other questions you had around that?
When would you consider testosterone?
Yeah. So when people come and see you for this hormone therapy, I like to kind of gradually introduce people into hormone therapy, because if you're suddenly throwing all these hormones at them, estrogen and then progesterone, it can be quite a lot initially. And we know from good evidence that all you might need is estradiol, progesterone, to help immediately, get rid of any symptoms that you have. Now, it has to be very symptom driven. So if a woman has hot flushes, night sweats, she's probably going to need estrogen and progesterone cover, and that is it. But if she comes to you and she says, oh, look, my hot flushes have gone away, my night sweats, but I still don't have that libido and my mood is a bit low, I do have fatigue, you could consider starting them on testosterone. Absolutely. I had this one patient who's in her early 80s who came to see me because she was on testosterone for many years, and there was no doctor who really wanted to keep prescribing the testosterone to her because of her age. And there's nothing in those textbooks to say you must stop hormone therapy at any particular age. There is nothing to say that you need to stop it. You can continue it. And I think most women should continue with hormone therapy if they're comfortable until they die, because we're menopausal. Imagine living till like you're 90. You've had 40 years without hormones. My God, like, wow. Okay. Anyway, she came to see me and she said, I really want to stay on testosterone because I notice that when I don't take it, I can't play golf so well. So she's hitting those balls. She knows, she's very straight, very strong woman, very educated, informed, in tune with her body, and is like, I really want to keep playing golf. I want to keep my strength up. I don't want to have a fall. I know if I have a fall, I'm more likely to fracture a bone. Having said that, she's not got even osteopenia at her age. So we continued the testosterone, and I will see her on a yearly basis to review things. So it's a very individualized thing, as you know, and like everything in medicine, it should be individualized. There should not be a standard cookie cutter approach, which is easy to follow if you're a practitioner because you have to think less. And I'm followed by a guideline. I'm covered, blah blah blah. But really, that's not serving the patient.
Absolutely. Yep. I would love to ask, because with estradiol and starting HRT, the guidelines are saying you've got to start before the age of 60. What about testosterone?
Yeah, there's nothing clear on testosterone about when you should start at that window of opportunity, as they talk about. Basically, it's about preventative medicine, isn't it? It's starting things at around 50, 51, which is the average age of menopause, things like estradiol, so that then you don't experience the osteopenia and the osteoporosis that eventually continues every year as we're postmenopausal. So it's basically getting in before things become an issue. I haven't seen any evidence of testosterone, but I could imagine, just like any hormone therapy, you start it at that time, within that window of opportunity, because we know there are benefits for bone health and muscle and overall general sense of well-being.
Fantastic. Awesome, Natasha. Where would you like to move on next?
Yes, so we were talking about
Yeah, benefits of osteoporosis, but also endometriosis.
Oh, yep. Well, the other notes pertain to, there was quite a lot of talk about obesity
Oh, yeah.
and weight loss medications. And as you know, a lot of women around the menopause gain on average 5 to 8 kilograms. It's usually visceral fat. They complain of that tie around the abdomen. And they often say, look, I haven't changed anything. In fact, I'm eating just as well, if not better, and I'm still gaining this weight. And metabolically, we know that at that age, we become insulin resistant, and we do have to change things up. We have to become more mindful of our diet, and perhaps eat lower carb, but not no carb. I don't believe that people should be no carb, because we know that long term that doesn't really benefit people. I don't think people can stick to no carb very well at all. No carbohydrates are very important for mood. And especially in women who are cycling, who have a regular menstrual cycle, carbohydrates are very important, especially in the second half of our menstrual cycle. The issues with the weight loss medications like the Mounjaro, the Ozempic, etc., is that, yes, whilst they help people lose weight, they also contribute to muscle mass loss. And we know that muscle mass is important as you're menopausal, because you need to be insulin sensitized at that age. You need to become more insulin sensitive, and we know that muscle is important for that sensitivity. So it'll be interesting to see what the outcomes are in future regarding that in that subgroup of women. The importance of protein intake for menopausal women, being mindful of each meal you have. How much protein are you consuming? Protein is so important. Where are you getting it from? I'm hoping that each practitioner that sees a patient who's menopausal actually says, okay, tell us about your protein intake. And then patients might say, I don't even know. What do you mean by protein? Where do I even get my protein from? And that would be a point at which you would then say, okay, let's educate you about what protein is, because that's super important. So protein, for the listeners, please go ahead and read up on that. There was a bit of talk about premature ovarian insufficiency, and how, it's not just women who are 51 going through the menopause. There are people who are less than 40 experiencing the menopause, and there's quite a lot of women experiencing it. And how do they usually find out that they're perimenopausal? They've been on the pill for a long time, and then they come off the pill because they want to have family, and then they're like, oh, well, I don't get regular cycles. And then after investigations, you realize this woman is menopausal. And so one of the reasons I kind of harp on about not being on the pill long term without big breaks is that you want to know what your body's inherently doing. If you're on the pill, you're never going to know that. As Lara Biden, the well-known naturopath, talks about, a bleed on a pill is not a period. It's actually a withdrawal bleed. It's an artificial bleed, which can often lead to false reassurance that we are hormonally okay when we're potentially not. So anyone who's out there who's listening, who's on the pill, you've got to review why are you on the pill? Do you need to be on the pill? And consider pill holidays.
So are you seeing, Natasha, quite young women in their 30s coming off the pill and not realizing they've entered menopause?
Oh, many.
Wow.
Yeah, many. So they come to you for fertility, and then you realize, oh, actually, this is a menopause it ends up being a menopause consult.
Wow. And how do they take it? Because,
it's a big shock.
Yeah. Especially if they're children.
Yep.
Yeah.
100%.
And what's similar in their story? Is it just being on the pill for like 15, 20 years?
Commenced, and this is one of the other issues I have, is that I see a lot of people who are commenced on the pill from a very young age, from 14, 15, not necessarily for contraception. I mean, contraception is important, especially in a 14, 15-year-old, because, hey, that's still pretty young to be having sex, but that's another story. You don't want a 14 or 15-year-old to be getting pregnant, so I understand the need for contraception at that age. But if a girl's having painful periods or heavy periods at 14 or 15, we as doctors need to do as much as we possibly can to manage that without just putting them on the pill.
Love that.
Because we know that long-term use of the pill, and the pill, when it's commenced in teenage years, long-term can lead to an increase in anxiety and depression, and even gut issues like ulcerative colitis, Crohn's disease. So,
wow,
that's huge. And then, you take these people off the pill and they're like, oh, I feel better. I don't have the anxiety anymore. There's a good book called How the Pill Changes Your Brain. And it talks about how if you're a woman and you're on the pill, you'll be attracted to different types of men compared to when you're off the pill.
No way.
Yeah, it's a great book. There's quite a lot of research on how the pill affects the brain. So we as doctors need to do more. You can't just go, yeah, let's just take the pill. Just take the pill. No, do what you can to avoid the pill if you can. And I'm sure you in your practice, you see a lot of this, and you've got that holistic approach where you approach every kind of aspect of someone's life. And we should do the same with teenagers and young girls, not just adults.
Absolutely. I loved what you said. And on that note of the pill, it's because it does reduce folate and that affects mental health. And then you've got, low magnesium, and then you've got poor nutrition. We're getting young and younger women with insulin resistance that I'm not even expecting. And as well affects mental health. So it's, the nutrition, the lifestyle, the sleep hygiene, the amount of time you spend in front of screens, which is affecting that. So all of that is actually really affecting your mental health. And then you add the pill onto it, which is another aspect, which I'm so glad you brought up, actually, because there are other ways of addressing heavy and painful periods for sure.
It's difficult to bring these things up to a teenager because they like diet. Oh God, what do you mean? Well, what's wrong with my diet? Or you want me to exercise? Or you want me to meditate? Meditate? What's that? And that's when it's important to have the parent in for some of the consult to be able to explain to the parent and to have the parent on board for that discussion.
Absolutely. And I loved how you mentioned about we're jumping different ages now, but we're going back to that perimenopause, weight gain, and the risk of insulin resistance. Absolutely. And it is reversible. You can do something about it with just knowing the principles of insulin. So often, we're snacking throughout the day. We shouldn't be snacking, keeping it to number of meals. I loved how you mentioned protein. I talk about protein with all my patients. That's the number one thing we tend to be low on. And why you don't feel full, hence why you crave sugar, hence why you snack. So just simple aspect of just increasing protein will just eliminate the snacking and the sugar cravings. And even that will lead to weight loss. It feels so simple, but it's so effective.
And if you can't actually physically get the food that has protein in it, do use supplements like a powder, a protein powder if you must.
Amazing, Natasha. I love where our conversation's going. It's awesome. So anything else that you felt, wow, I didn't know until
there was a great scientist from Germany. I think his name escapes me. I could give it to you and you could put it in the notes later, but he talked about the different types of progestins.
Oh yes.
And remember how the WHI study came out and it showed in 2002, and it showed that and it's been debunked since, that combination HRT containing medroxyprogesterone acetate and the equine estrogen increases the risk of breast cancer. Well, obviously there's been lots of studies since then, and what's really come out is that it's the type of progestin in the hormone therapy that could potentially increase or be associated with the risk of breast cancer. So not estrogen maybe per se, but progestin. And there are different types of progestins that we use in hormone therapy. And probably the safest one is micronized progesterone, which is why formulations like Estradiol Pro are currently probably the most popular formulation. So that was really interesting. And the way he talked about the genesis of breast cancer was quite fascinating. And how, women should also review their alcohol consumption at this time because, hey, you have 2 or more drinks of alcohol per day, you're actually going to increase your risk of breast cancer a lot more than HRT.
Wow.
And that puts things into perspective. There's a fantastic psychiatrist in Melbourne, Dr. Kulkarni, Professor Kulkarni, you probably know her.
Yeah.
She was there. She gave a few talks. She's great to listen to. But she's developed a questionnaire called the MENO-D questionnaire, and it's designed for perimenopausal, menopausal women to fill in. And once the person who's filled it in, you review it and then you come up with a score. It enables you to determine whether someone needs to see someone for help for depression or whether you could just put them on HRT, because we know HRT can help with anxiety, low mood. So it helps kind of stratify someone's need for assistance. So I've started using that since the conference, and that's been quite helpful. So MenOD questionnaire is, if you type that into Google, that'll come up.
On a side note, and sort of along those lines, what do you think about the aspect of stress and the hormonal changes that women go through during menopause?
Yeah, well, we know that stress contributes to so many things, right? Poor sleep. If you sleep poorly, your ghrelin and leptin hormones will be disrupted. So your ghrelin will go up, your leptin goes down, your cravings change in the day. You'll make poorer food choices. You won't have the energy to exercise. You'll be fatigued. We know that cortisol, you've heard of that, about the progesterone steal. So that basically that if you're stressed, you'll make more cortisol, particularly at night, and that will impact the amount of progesterone that is made in particularly the luteal phase of the menstrual cycle. So you see it quite a lot in women who have significant PMDD or PMS, how stress management can benefit those symptoms. But yeah, stress, huge. When we stress, we tend to, drink more. What's our crutch? Is it high carbohydrates? Is it alcohol? Yes. And we know that women who are perimenopausal, menopausal, they have so much going on. They usually have, they're women who are working women. We know who, most women have to work, given the expenses in our society at this stage. They have children, and we know more women are having children at a later age. And so, they've got kids, teenage kids when they're 50. A lot of women, and teenage kids are not easy from what I understand. I've got a couple of nieces, but I don't have children myself. They've got aging parents. So many things are happening at this age. So, yeah, I mean, if you can sleep and stress.
Absolutely. And that's literally how I educate my patients, because sometimes we underestimate how much stress you're in, but the impact it has on the hormones. I love explaining what happens in the adrenals and pregnenolone steal and the impact of just being in chronic stress. And it could be just simple changes. That's when it goes right back to reminders of simple changes of lifestyle, deep breathing, sleep hygiene, movement, and nutrition can actually make a huge impact. And often, actually, I've got some amazing stories where often women go, what am I doing? What am I doing in this high stress job? How am I leading my life? At last, they start prioritizing themselves and putting themselves first, and actually really nurturing themselves. And then they see the impact it has on their hormones and mood and weight. So I think it's a real important message to send. I think many women, I've heard so many stories when you ask, what do you do for yourself? They actually go, nothing. So it's because it's about giving to the family, putting their kids first, putting their family first. And they're very easy to lose yourself in that. And then it comes to all these symptoms where it's unbearable, whether it's night sweats or the mood dips, especially like before your period, or heaviness. And when it becomes unbearable, that's the pain points that you go and seek help. And it goes right back to the impact of chronic stress as well. So I'm so glad we mentioned it, Natasha, because I think it's a great reminder that simple changes can actually have a positive impact.
That's right. Even just going for a daily walk on your own, a bit of me time.
Absolutely.
Self-care.
Yeah. And before we let you go, Natasha, is there any advice that you would love women who are thinking, wow, am I going through perimenopause, menopause? What can I do? Often patients may feel, or women may feel, wow, is this it? Do I have to suffer like this?
I think get help, but first and foremost, read books about the topic, and go to a bookstore, pick up an actual book about the topic, perimenopause, menopause, be informed, and see a doctor who has an interest in the menopause. Not all doctors do, unfortunately, but not all doctors. We know, as you know, there's only so much information we can hold in our heads. We don't know everything as doctors, and nor should we pretend that we know everything. So obviously we all have different interests as doctors. I have an interest in the menopause. And so I think it's important for patients to seek out practitioners that have an interest in their condition, just like you would if you had, like, I don't know, a back problem, or any musculoskeletal issue. You would seek out a physio or a surgeon that has an interest in knees or shoulders or ankles. It's the same with the menopause. You got to seek out the right help.
Amazing. And any books that you would recommend? Is there anything that comes to your mind?
Yeah, the Mayo Clinic, there's a book called The Mayo Clinic Menopause. It's great. There is Jennifer Gunter, I think her name is. I've got so many books. There is a woman called Dr. Marie. This is probably, the hottest book on the market at the moment. It's called The New Menopause by Dr. Mary Claire Haver. She's an American woman, and everyone is talking about her. She's big on social media at the moment. I really like Lara Brydon, is a naturopath, a very good one, very knowledgeable, who was formerly working in Australia. She's actually Canadian, but now living in New Zealand, and she's written some great books about women's health. So Lara Brydon. Australian Menopause Society is a great website for people to visit, and the Jean Hales Foundation as well. I think they're the only two really good websites to visit initially for lots of information.
Amazing. Amazing. So thank you, Natasha. So where can people find you?
Well, I'm based in Sydney, Newtown. I do lots of telehealth as well. So wherever you are in the world, I Zoom with patients from overseas. My website is newtownfertilitycentre.com.au, and I'm on Instagram as Dr. Tash, the Fanny Mechanic.
Amazing. Amazing. And of course, you've got your podcast and that's still going.
I haven't put out too much this year because I've had so much going on. And the last one I did actually put up was about the menopause, coincidentally. So I'm happy to put up more next year.
Amazing. Amazing. Thank you, Natasha.
Thank you, Shemi.
Remember that this is general advice only. Please see your healthcare professional for more information. So what's your take-home message today? Remember, it's all about progress and not perfection. And are you suffering from stress? Visit the Usawa Learning Hub on usawa.com.au for more resources on how to de-stress, re-energize, and reclaim your health. Enjoy the journey.